social media as a singular video. So I've decided to group some of these together. If truth be told, the majority of procedures that we perform in clinic, it takes no more than a couple of minutes, both ears. So these are kind of your more day-to-day procedures that we encounter in clinic. I think there's one challenging one thrown in the mix, but so this is patient 1, ear 1. As you can see, their left ear is completely blocked. They've got this soft consistency of earwax. It's quite dark, so it's potentially been there for a while. It's oxidized. Their right ear, which you would have also seen, the clear part was completely clear, so it's just their left side. And just slowly but surely teasing this out of the ear. There's a few hairs matting on this blood wax. There's a bit of skin enveloped around the circumference of it. So even at this stage, the patient's able to hear significantly better, and that's because the ear is no longer occluded. There is an opening in the ear canal for sound and air to enter, for sound waves to hit the eardrum or to vibrate it. So we've just got some peripheral dead skin just around the edge of the cartilage portion, so just use the fine end, just glide around. If it comes away, brilliant. If not, it's completely fine. The eardrum is intact. I think there is a very mild atrial retraction. So as I started peeling some of that skin, you can see some of this dead skin started to peel away towards the eardrum as well. So just going to do as much as possible, but without taking any silly undue risks. So the skin's not really going to cause a massive issue. It potentially may not migrate by itself, and that's why this patient in this left ear originally had a dead skin and wax forming. So the skin that lines the ear canal, as it dies and sheds, the ear over millennia has developed the unique property of ensuring that the skin moves sideways as it migrates away, moves like a conveyor belt, and really waxes on the surface of the skin, is therefore also transported out of the ear. When people do attend the wax impaction, that's one of the plausible causes as to why they are experiencing them. So the skin is just not migrating, or the ears it's not migrating quick enough. So the ear is producing wax at a quicker rate, and the ear is able to naturally expel it. Other potential reasons are that the earwax glands. So there's earwax is a mix of 3 primary ingredients. The most common ingredient is what is called dry matter. We're going to categorize it. It's dead skin cells, exfoliated within the ear, loose hairs and debris. So that's all the dry matter, around 60%, and the remaining 40% is a combination of sebum, which is an oily fatty secretion, also found on the scalp, and an oily sweat, which you can also find in our armpits. Then they all amalgamate, and it could be that these glands that produce the oily sweat, so they're modified apocrine glands or sebaceous glands that secrete sebum. They're just hyperactive, so they just produce oils and sweats at a quicker rate than normal. So patient 1 done. Patient 2, it's very similar as you probably saw. It's their left ear again. Weirdly enough, and I don't think there's anything, it's probably just coincidental, and I've never done really any extensive research, but quite commonly if a patient attends with earwax in one ear, it just seems to be the left ear more than the right. I really don't think there's anything more than just being coincidence or me getting my observations not correct, but it's something that I've always kind of again, it's just between its left ear. So this wax is a bit more softer, and we have used some oil, and just slowly moving it. And I think this is a slightly longer one if memory serves me correct, just because they have got quite a bendy ear. You can see that there. I'm having to go in and go all the way to the right, stretch the ear open, and then insert the suction probe. And I think they've also got quite a prominent anterior recess. So if it's not this patient, it's another one. Try removing wax from the anterior recess. It's very difficult because the bending nature of the patient's ear. The fact that that recess was it's really tucked away in the corner. So you can see once again there's a few hairs here. Now, hairs that in the ear should only be found out of there. That's the cartilaginous portion of the ear canal. And that's because the skin that lines the cartilaginous portion contains the dermis layer. The dermis layer is where you find the hair follicles, which of course where these hair strands then protruding outwards from. The skin that lines the inner two-thirds of the ear canal, the bony part, we only have the epidermis layer, so there's no hair follicles located on the inner two-thirds of the ear canal. So these hairs are most likely either been pushed into the ear, or when this patient has had their hair trimmed or the ear hairs cut, they may have just flown into the ear canal. So that's another plausible cause. So just using the fine end now, if this wax is a bit firmer and drier, what we would have probably found is that this residual wax would come away a lot more easier. But because it's quite soft and loose and mushy, you can see it's just not coming away. Now, patient can hear a lot better again, so whenever we perform wax removal, the main objective is to make sure the patient's ears are clean enough so they can hear. Earwax removal cannot be compared with car cleaning, and it's a really important distinction to make. We're not, so when you get your car washed, you do want it washed completely. Earwax removal is completely different. In fact, earwax is a natural health secretion produced by the ear, and it's designed to serve and protect us, and it does that in many different ways. Earwax is mildly acidic, so the acidity helps to repel insects, believe it or not, entering the ear. The acidity also helps to inhibit bacterial and fungal growth. This is bad bacteria, bad fungi. There is a natural bacteria and fungi that actually reside on the skin. We call it skin flora. So there is some healthy bacteria and fungi that is accustomed to the natural pH of the ear. So these are healthy bacteria and fungi which protect the ear from more harmful bacteria and fungi. So the acidity helps to inhibit harmful bacterial and fungal growth. Earwax is also hydrophobic, so it helps to repel water out of the ear, because water is bad for the ear. It's sticky, so it attracts any dust, dirt, pollen that may enter the ear. And as I mentioned before, earwax typically makes its own way out of the ear. And earwax is oily and greasy, so it helps to moisturise the skin, keep from drying and cracking. So there's many benefits to earwax. And of course, when you've got a build-up like this, the patient has, then it's counterproductive. Other plausible reasons as to why people get build-up of wax, in addition to those earlier reasons I listed in the first case, is like this patient, they've got a very bendy, twisty ear canal, so as the wax is travelling around the bends, then it slows down the migration. So you get a build-up. If you've got a tremendous amount of hairs, then the wax can mat against it. Now, in some literature, these hairs are described as being there, not only produces oils and sweats, but also to help earwax naturally migrate. I'm not sure if that's so true, but it may well be. It's just something that I don't see why the hairs would help the wax naturally migrate. It's more jaw movements and this natural skin migration that I described earlier that are the main causes. If you've got any abnormalities of the ears, if you've got any abnormal widenings or erosions and potholes, wax can drop down these potholes and widenings and find it difficult to migrate out, so that's another reason. Patients with really, really narrow ear canals, so we do see a lot of patients with Down syndrome. So Down syndrome patients do have very narrow eustachian tubes, nasal passages, and also ear canals, so they tend to require a lot of de-waxing in their ears. I'm just trying to think of other reasons. And probably the most common reason though is self-inflicted, when people try and clean their ears out themselves. It's actually just pushing it further in, unfortunately. Now, when you swivel and swirl around a cotton bud in your ear and you remove it, you may see some residual wax on that cotton bud, but that's an invisible layer that's coated the canal wall that's there to protect it. If you think about furniture, and you varnish it, think about earwax as the same thing. It's just a varnish, so to speak. It helps to protect the ear canal. So just using the fine end, you may have seen that I've just bend the fine end just to get access here because it was so bendy and twisty and narrow. Now, we're not going to get all of it out, guys. So please refrain from sending me any hate email. Sometimes we do get if we leave a bit of wax behind. I know some of you probably think, really? Yes, we do, unfortunately. So let's do my best to be very respect. Then there comes a time when it's like, so we just, it's always a benefit-risk ratio. Now, we're in someone's ear, we're vacuuming, it's a bit noisy, we're using a fine end, so we're minimising that. But with microsuction, probably the biggest risk, if truth be told, it's not perforating the eardrum. Although I'm sure that obviously there is a risk, I can't deny it's not, but it's mainly the noise. So with microsuction, you can all imagine if you've got, I no longer do, some headache maybe, but when I used to be younger, so I attended a lot of concerts, gigs, loud, noisy environments, and I used to come away and my ears used to ring for a day or two. That's because your ears are taking a battering. We all got these little microscopic sensory hair cells within the organ of the cochlea, and in response to loud sounds, we get a build-up of unwanted toxins that your ear just to flush away. And also, these hair cells undergo physical contortions and distortions. They lose their shape, and your ears need around 48 hours to recover, and during that 48 hours period, so until these hair cells reshape themselves and the ear flushes out all these unwanted toxins, we can experience a temporary reduction in hearing, and also a bit of tinnitus, or really a buzzing noise in the ear. So. And that's, guys, that's 3 on the trot. So this is patient 3. So you can see there's a bit of little wax left, but the benefit to the risk ratio was outweighed, so we left that. Patient here, not a problem. Hopefully that little bit of wax will migrate on its own accord. There's no wax sitting in front of it now. And no, we're not going to irrigate that. Definitely not, because irrigation has far more risk, especially in a patient's ear like that. It's very bendy and twisty, and the water can get low. Water's just going to wash away the natural lacquer, that veneer, that varnish that I described. You'll probably put that ear at more risk of then leading to an infection. Yeah, we don't really want that. But this is the 3rd case on the trial. These are old videos, guys, so I'm not deliberately putting them together in such a way to show you that. Again, this patient's got just earwax infection in the ear, and it's their left ear again. So how strange. And again, I'm sure it's just a coincidence. I might have to just start documenting actually and see what I can make specific, and then do a statistical analysis, which I've done previously as part when I was doing my PhD, but I probably won't be able to do it anymore. It's been a long time, so I'll have to get someone to do that on my behalf. But just to see if there's anything more into it. Who knows? It could be that if we're right-handed, for example, our left ear is it's configured in a certain way in comparison to the opposite ear. It could be some sort of evolutionary advantage of one ear being a certain shape to pick up certain sounds, and obviously the curvature of the ear will have some effect on the resonance of the ear. So when I say resonance of the ear, imagine you've got 5 empty bottles, and you fill up those bottles with water to various differing degrees, and then you then blow the top of the bottles. Because of the surface area and the amount of water in each bottle, when you blow the top, you get a natural resonance. The tune produced by you blowing over the bottle will be different for all of those bottles. And the ear itself, the diameter, the length, the curvature, the amount cartilage, bone, these can all affect the natural resonance of the ear. So the natural resonance is a frequency that's naturally amplified by a certain cavity. So if you think about musical instruments, the bigger the internal cavity of a musical instrument, so percussion wind instruments, they're going to produce a more lower frequency sound, and the smaller the internal cavity, their natural resonance is more of a higher frequency sound. So again, this patient's got a really twisty, bendy ear, you can see, and the inner third, I will say, the skin's really dry. You can see there, the skin's dying and it's cracking. So this earwax, and it was more natural, it would appear that it's not dissipating. So although the majority of earwax is produced on the outer third, this earwax should then spread, it should dissipate itself across the entire ear canal, and also the eardrum to moisturise the entire ear. But in this case, it would appear the inner third, the skin is quite dry. You can see that quite a distinct border. So that's a bit interesting there. Again, this wax that I'm removing, it's on the outer third. I would definitely 110% not be doing this on the bone top because it would be uncomfortable for the patient. Yeah, it's not an invisible layer, it is visible, but it's not a clean ear, so just remove as much as I can without causing any trauma to the patient. The eardrum is entirely visible. You can just see the curvature and the architecture of this ear. I'm looking straight into it. You've got this massive upward sloping incline, this peak, and all of our ears do incline upwards around 30 degrees, but this is quite significant. It's like in excess of 45 degrees there. And then the ear drops down and it veers off to the left. So yeah, it's quite a challenging ear for that reason. But fortunately the wax was more lateral. The wax was deeper in the ear. Just like the patient before, that was probably not as bendy and twisted as this though. It may have been a bit of a challenge getting a deeper wax because we'd have to straighten this ear. If our ears were straight, it would make earwax removal a lot easier. But the fact that they're not, and they're designed not to be straight for a reason. Our ears have evolved to be in this shape, have a sigmoid shape, to protect the eardrums. If you've got a foreign body entering the ear, it's going to have to navigate across these bends before making contact with the eardrum. So this is next patient. So in this case, their left ear was fine, it's their right ear, as you can see, that's blocked. The reason why I probably looked twice in that patient's left ear, remember these videos are quite old, I'm just going through the catalogue to show it, upload some of the shorter work videos. It's possibly because they've got a slight attic retraction, so that the top part of the ear was buckled inwards slightly. So I'll describe that a bit more during the course of the video. So this patient's right ear, this is all dead skin. So if this was my ear, the skin would have naturally migrated outwards. It's dyed, it's shedded. But you can see the skin, it's still attached to it there. So when the skin is lining the ear canal itself, you've got these individual skin cells. They're called squamous skin cells. And the term is squamous, and it's Latin for fish scale. So that's how it looks. And they are interlinked. So it's almost like a lamellar structure. But when the skin dies, sheds and starts to migrate, these individual skin cells just separate from one another. So this link should slowly be broken and you get individual skin cells and then exfoliate out of the ear. But in this particular case, you can see the skin and also most skin peels that we've been before, the skin has found to, these individual skin cells still remain together. They haven't disengaged with one another and interlocked. So we're just peeling that away. So yes, it is my, the skin will naturally come out. At this age, now in the future, who knows, my skin may also stop migrating as it should be. So yeah, I might yet to reduce blood flow. The skin can get dry, which is common as we get older because our eyes produce less of these natural oils and sweats. So you can see there's got this thin layer of skin still on the eardrum, just slowly bringing it away. Just gently peeling away. You've got an amazing view of the eardrum there. The eardrum slowly starting to reveal itself. I'm not going to lie, that's quite satisfying to watch back. I know a lot of patients, a lot of subscribers, viewers, followers of the channel really enjoy the skin peel for that reason. So still a bit of crumpled skin inferiorly, we're just going to see if that comes away. But of course, we're so close to the eardrum now, we'll be really, really gentle. I'm not sure, let's see what happens. Okay, so there is a sheet of skin extending out of the eardrum, but I don't think it's going to come away fully. Let's see. Yeah, I'm happy with that. nothing on the eardrum. It's more in the anterior recess, like kind of wall, so it's going to be also somewhere. This eardrum doesn't look retracted. I'm not going to go back in. You see. Now you may have seen at the eardrum this white perimeter. We call that the annulus. I think in this patient it's been between 2 o'clock and about 11 o'clock or 10 o'clock. The annulus is what stretches the eardrum. And it's made of a fibrin cartilage. So that's what that part of the eardrum is. This is another patient. I think we're evening ourselves out now. So this patient's left ear. I remember this ear. As soon as I enter it, by looking at the video, this patient, I'm 100% sure, has got, we can see the head of the stapes bone, the eardrum retracted. Yeah, there we are. This is a patient that has to come every year. And it's something about their earwax that I can recognise this patient's ear straight away. And with this patient, it's always their right ear. The left ear is fine. And again, I think the reason why this patient's getting this wax and also a lot of dead skin build-up is because of their retraction. So I talked about anatic retraction earlier, so let me just discuss what I mean by retraction. Behind the eardrum, we have what we call the middle ear. The middle ear consists of the 3 little ear bones and the eustachian tube, which is a narrow orifice that connects the back of the eardrum, so the middle ear to the back of the nose. Now, ideally, we want the air pressure in the middle ear to be equal or similar to the air pressure in the atmosphere, so in the ear canal. And therefore, it's the function of the eustachian tube to equalise the air pressure, so it allows air to either enter the middle ear or exit the middle ear in order to equalise it, depending upon your altitude and the air pressure you find yourself in. So this eustachian tube, it connects to the back of the nose, and that's where it opens and closes. And at normal resting state, the eustachian tube is closed. It's closed for a good reason. It prevents you from hearing your own voice louder in your head and causing any distortion to your own voice. Because if your voice travels up the eustachian tube and it hits the underside of your eardrum, and it's also going to be heard externally, so when you talk, your voice gets projected out, it's going to enter your ear canal. You're hearing your voice twice, not only up your nose, up the eustachian tube, but also from the external ear canal. And they're going to arrive at the eardrum at different times. They're probably going to reach the eardrum quicker up your nose, up the eustachian tube, in comparison to the ear canal, because it's got a shorter distance to travel. So you'll hear yourself twice, you get a muffled voice. So the eustachian tube normally is shut for that reason, and it's also shut to prevent any upper respiratory tract infection from travelling up the eustachian tube and infecting your middle ear. But during brief moments in the day when you swallow, you want to chew the eustachian tube, the muscles either side where it connects to the back of the nose, they contract, causing the eustachian tube to open and allow the air to equalise. So this is the same patient, this is their left ear, if I'm correct, yeah, it's a little bit skippy. Don't think I charged the patient for this, we're just going to give it a quick clean-up, just any large bits, we're not going to give this ear a car wash. Just going to put it away. This is probably not going to come out if I'm honest, it hasn't in the past, so this always mop it up. So yeah, when the muscles contract, the eustachian tube opens, the air pressure can equalise, but if the eustachian tube fails to open, and it could be because 1, the patient's just anatomically got a very narrow eustachian tube, 2, the muscles have become paralysed or weakened and they contract, 3, there may be some physical obstruction, so nasal polyp for example, or a deviated septum, or 5, an infection, so rhinitis, sinusitis. So there's probably other reasons as well, so allergies, any congestion, mucus there. All the remaining, so air can't travel up the eustachian tube, it can't equalise the air pressure. Any remaining air in the middle ear through gaseous exchange is absorbed by the cells, the mucosa cells lining the middle ear, and until eventually there's no air whatsoever in the middle ear. That creates a vacuum, your eardrum gets pulled in, and that vacuum then causes fluid within the cells lining the middle ear to be released into the middle ear, and this fluid should drain out of the eustachian tube, but because it's blocked, it can't. But when you get that vacuum effect, when your eardrum gets pulled in, we call that a retraction. So on that one case where I re-entered the patient's clean ear, with their left ear to look, there was an active retraction, and nothing significant was there. With that patient I just treated on the right side, their eardrum has been like that for years. They've seen ENT, no further treatment required. But their eardrum was so sucked in posteriorly to the back part when it was actually, it's causing erosion of their incus, which is the middle ear bone. When the ossicles in the middle ear can begin to decay and get infected, we call that process necrosis, osteonecrosis. And it could be because it's an infection in the middle ear, like cholesteatoma, or even the lower ear, over a prolonged period of time, or when the eardrum is sucked in, it can actually wrap itself around the bone. And that incus bone is quite susceptible to the long process. And when that eardrum is sucked in, think about it like a piece of cling film, which is it's a good comparison actually, the eardrum to a piece of cling film. It wraps around the bone, it compresses and constricts all the blood arteries and capillaries, so the bone is then starved of all the oxygen and nutrients it requires, and it begins to decay. So in that particular patient, the posterior, the long process of the incus has eroded because of this severe retraction, which has meant we can see the head of the stapes. So the stapes is the smallest bone in the body, also known as a stirrup. It attaches to the organ of hearing via the oval window, and the joint at which the stapes bone connects to the incus, we call it the incostipedal joint, but it's the head of the stapes that connects to the end of the incus bone. And that is visible. It was like a little ball socket, like a socket joint, ball socket joint there. It's the eardrum wrapped around, but the patient doesn't actually have much of a hearing loss there. And that's because that stapes is being directly stimulated by the eardrum as it's attached to it. So ENT have discharged the patient. It's not causing any problem, just apart from skin build-up and dead and wax. And when you've got a retraction of the eardrum like that, I often find that you do get a lot of dead skin build-up, because remember, the skin starts to die and shed and migrate from the eardrum itself. The outer layer of the eardrum is made of dead skin. So if there's any abnormality with the eardrum, so a retraction for example, skin can sometimes get trapped and it may not fully migrate out of the ear. So this is another patient here with quite soft, sticky, waxed skin just at the entrance of the ear, and just trying to lift it away from the base of the ear canal. You can see it's really got this adhesive property, and there's a bit of dead skin on the right hand side that's attached itself to the wax plug. So just manipulating this. Oh, it came out a big plug, which is great. See at the entrance, quite a hairy ear, so a few hairs in the ears as well. Some of these hairs that are actually in the ear, they're not always loose hairs, they're hairs that are still attached to the outside part of the ear, so the front part of your ear, of your cheeks, and they actually kind of go into the patient's ear. They're that long that they somehow, so still the root is external, but the tip goes into the ear, so we can actually move them sometimes just by moving your finger across the patient's top of their ear, and you'll remove any attached hairs. The patient's skin is quite dry. You may see that, especially at the entrance. Again, these videos are quite old, but pretty sure this patient would be, just from their ear profile, more elderly and most likely male. And that's because as we get older, the skin does become drier. Don't get me wrong, you can get younger patients who have dry skin, of course, but it's more prevalent in the older populations, and that's because your ear is producing less natural oil, so it can't moisturise the skin as well. And of course, with these hairs, it is a male thing, unfortunately. I'm experiencing it myself. Your body stops growing hairs where you want them, i.e. the back of your scalp and the crown region, and you start growing hairs in places where you don't really want, so on the side of your ears and in your nostrils. And I would, that is definitely more gender specific. I think there's some research about it as well. I think it's kind of more testosterone buildup. This patient would fit more of a male, older patient. And similar to this one, I think this is a different client. They've got all these hairs, matted, quite dark wax. This patient has got somewhat a collapsed ear canal entrance, so the cartilaginous portion of the ear canal, as we get older, is more susceptible to collapsing. That's because the cartilage can weaken over time, and the back part of the cartilage of the ear can continue to grow, so it has less structural support. If you think about our nose, now our nose is configured similar to our ears in some respects. It's subdivided into cartilage and bone. I think with the nose, it's the lower 2/3 is made up of cartilage and the upper third bone, whereas our ears is the outer third cartilage and the inner 2/3 bone. The tip of our nose, as we get older, the cartilage is just more susceptible to weakening, and it's partially because there's less blood flow there, less vascularization, less transfer of nutrients that the ear needs. And then gravity takes its effect, so you get a droopy tip sometimes. Something with the ear, you get a collapsed canal. If it's due to overextension of the back part of the cartilage, I know some surgeries that kind of trim that, just give it some more structural rigidity, but if it's just the only problem it's causing is a once in a while cleaning the ear, it's not really, again, it's that risk-benefit ratio I discussed about earwax. There's no real benefit of patient undergoing surgery to increase the aperture of the ear canal if it's just the alternative is to get your ears cleaned out once in a while, which is what's happened to this patient. So now I know this patient, I can kind of remember this patient actually, because it's a regular patient. It's like that other patient where I said immediately this patient's got a retraction of the back part of the eardrum. This patient does trim their ear hairs, and they are starting to now just place some cotton wool at the entrance to prevent hairs flying in as they're trimming it. It then can mat against the wax. But otherwise, the ear is quite healthy, as you can see. It's got a nice colour to it. It's nice and pink. The inner 2/3 of the ear can at least appear very hydrated. The eardrum is nice and healthy. You just see how collapsed that is. It's hard to get the instrument in. So yeah, there's probably going to be a bit of debris left behind, but that's fine. Hey guys, it is fine. I will take a picture of my ear. I've got some bit of wax on it, but it's there for a reason. Now this is, I think, the last couple of procedures. This is a lovely gentleman who actually just came recently. They watched my YouTube videos of Luton. They owned up straight away. Yes, they have been using cotton buds, which is pretty obvious, you can just tell anyway. So, but yeah, just going to remove this. And they have got a bit of a narrow junction of the eardrum as we approach the ear canal as we approach the eardrum. So this is lodged, just going to slowly wriggle it out left and right. You may be able to see that narrowing. You can see the perimeter of the ear canal, and then it widens. You can see I'm bringing that plug through the widening on the right side. That's where the ear canal kind of balloons and protrudes outwards. So that part of the ear is called the isthmus. So it narrows and widens, and quite often use a cotton bud and kind of wedge wax into that recess, the anterior inferior recess. So we just pull that through. This is more superficial. Yeah, if I'm going to hover over it, I can get it. Brilliant, but we don't want to spend too much time with the patient sitting necessarily without any massive rapport, because again, if you remember earlier, you're exposing the patient to sound. Yeah, we're using the fine end, so it's not it's horrible, it's not excessively loud, but still. The last thing we want to do is cause a microabrasion or cut of the ear canal. We don't want to leach this ear completely with wax. Now, with suction, it's really impossible to do that, because even if, when I remove this, you may see the canal wall and think, brilliant, I've got all the wax out, but there's a thin veneer there, guys. Just it's invisible to the naked eye. And we don't want to remove all that, we want that. After I shower, the side of my lips get very, very dry, and if I don't put any moisturiser quickly, the ears will dry and crack. We're talking about 10-15 minutes, it really does get dry. The reason for that is obviously when I'm showering, I'm using soap, I'm washing away these natural oils that my skin produces, and I would suspect that I don't produce much in that region. So So anything that I do produce is washed away, it's leached away by the hot water, especially can cause that. Soap, and then the skin that lines that either side of my lips is exposed. It's got the oily membrane sitting on top to help it retain its natural internal moisture, so that the moisture within the skin rises to the surface and it evaporates. So I have to put moisturiser every time I get water on my face, really. So that part of my mouth is quite sensitive. So this is the same patients as on that side again, just teasing out. You can see all those hairs up there. They shouldn't be there, but again, the patients